Good afternoon, respected Chair, friends. First of all, I thank Dr. Veeramani and the TNCSI team for this opportunity. So I will present some challenges in balloon mitral valvotomy. BME, we know that it's become a standard procedure with a fluoroscopy time of less than 6 minutes and a procedure time of 30 minutes we can achieve in most of the cases. I'm not going to those details. We know the anatomy of the valve where the commissures are fused and we have to open the commissures. Here with the echo, you can see that the commissures are open, and these two, both are open, and this is a good result. So the challenges can be in the septal puncture and dilatation, difficulty in crossing the valve due to abnormal anatomy, pregnancy, it is difficult due to many reasons, and left atrial thrombi. These are the things which I am going to discuss. This is one of the challenging cases where there is a huge left atrium. You can see that here you can see this is the right atrial border. You can see that the left atrium is forming the right heart border. So in this case we tried to descend. We usually descend in the AP view, then confirm it in the RAO view, and the LAO view the septum is end on. And the RAO we thought it was okay, but when we checked, we always check in the lateral view and found that it's very much anterior and we were not able to puncture. We tried multiple times. So when we readjusted, you can see that the needle is pointing in a very different direction here. So multiple attempts we couldn't do, and then we tried the probing left atrial entry. What we do is we keep the needle inside the Mullin's sheath or the dilator, and we try multiple times, and now we were able to enter. Another case where we had a difficulty in entering, this is the probing left atrial entry. You can see that the needle is much inside the Mullin's dilator, and we are probing that PFO area and trying to get inside, and you can see that we have gone inside. And this is a publication by Dr. Krishnamurthy which has shown that in 90% of the cases he could enter if you probe continuously. And the other area is a septal catch. So we try to enter to pass the balloon into the left atrium after putting the pigtail where you are not able to enter. We can try a dilatation with a larger dilator, which is 14 or 16 French. And still the angulation, the difficulty may be due to an angulation because you have punctured the septum little vertical. It may not be going inside. So you change the angle. You can see that once the angle is changed, the balloon goes inside easily. The next difficulty can you get is many of the times our balloon may get stuck at the septum. So here it also may be due to the angulation of the puncture. Here we can reintroduce the pigtail, release the balloon from the septum, redilate the septum with a larger dilator, and push the balloon more into the left atrium and try a hairpin loop as we are doing it here. For this you have to have a roomy LA. You push the balloon more into the left atrium and push it towards the floor of the left atrium and push the balloon across the mitral valve. So this is the hairpin loop entry. And the reverse loop entry, when you have a difficulty, especially when your puncture is much below, you may not be able to directly track the balloon across the mitral valve. So here you have to use a reverse loop entry. For this you have to have a large left atrium. Here you are seeing the one thing you have to remember is that always when you are doing a reverse entry, always go to the apex. Otherwise your balloon may be going between the chordae and you can damage the chordae and produce mitral regurgitation. So to form the reverse loop, either you can try with the balloon or you can use the pigtail wire. You turn the wire 180 degrees and put the loop towards the opposite side. Usually we have the loop on the right hand side, on the left hand side, and form the reverse loop. This is how to form the reverse loop. And when you do the reverse loop, you usually do the anti-clockwise rotation. The reverse loop you always do the clockwise rotation. And this is how. This is the one I said that always go to the apex and make sure that your balloon is not going through the caudal structures. And unable to cross the valve, that's the next difficulty. Change the shape of the stellate. You can use an over-the-wire entry. There are different techniques. Change the puncture site. Somebody has suggested filling the balloon with CO2. I have not tried. And a retrograde entry. So the changing the shape of the stellate, if you use a high puncture, you can increase the length of this that area of the loop, and if the lower puncture, you can reduce the length of the loop. The over-the-wire techniques have been Dr. Manjunath's group have done so much work on this, And they use the pigtail wire itself. They use a sheath and put the pigtail wire into the left ventricle. They have done a lot of cases. They say that it is only some problem due to the ectopics. Otherwise, they do a lot of cases. This is another technique which we have done. We keep the balloon is not entering. We keep the balloon at the mouth of the mitral valve. We use pass a usual O35 wire and track the balloon over that and dilate. And the Jomaiva balloon, I think some of the hospitals are using this Joseph's mitral valvotomy balloon developed by Dr. George Joseph. This is an over-the-wire system. You can see there is a sheath somewhere here, and this is the over-the-wire system, and this is a reusable type of balloon. Luton-Basher syndrome is another area where we can have difficulty, but we think that it may be easier because you already have an ASD, you just enter, but you will struggle in those cases because you don't have the support of the interatrial septum to direct the balloon towards the valve. So in that case, you can try this over the wire, one of the over the wire techniques. Then next is the non-yielding valve. So sometimes whatever you do, the valve may not be yielding. So what you have to do is don't take a larger balloon. You take a smaller balloon and go to the fuller size. So 24/24 is better than 26/26. I will show you the chart. You can see that the smaller balloon will have a higher pressure generated compared to a larger balloon. So the chance of opening up is much better. Both. Yeah. 24/24 is better than, because 24/24. No, 24/26 will be much worse. Much worse. So 26/26, 24/20, you take if you are not dilating even at 26/26, you take a 24/24. That will be better. That is what the charts show. So you can see this is that example. It will generate more pressures. Compared to 2, it will generate a 4 atmosphere pressure. Then post-mitral valve repair and bioprosthetic valve stenosis, we have done some cases. This is a case where we have done this is a young boy who had a mitral valve repair with a carpenter ring, got stenosed. There was no other option. We went ahead and did a balloon dilatation. Good result. I think 5 years when follow-up is doing fine. This is another case with a mitral bioprosthetic valve. This is 3 cases reported from Army Hospital. The problem is here we have 3 leaflets instead of the 2 leaflets in mitral valve. But here they have done, Dr. Datta has done 3 cases and showed good results.
What balloon did they use?
Iron balloon. Regular iron balloon. Maybe little small. He said probably he will not go to the larger size, maybe little smaller size. Sometimes you may not get an access from the right femoral vein. You may go from the left. You may have to go from the left femoral vein. So here this is the left femoral vein. You have to make a little adjustment. You have to tilt the patient at the hip towards the right side so that the angulation of the septum will be much better. And severe subvalvular thickening is another area where there can be difficulties. This is also reported by Dr. Manjunath's group. What they do is they pass once we are not able to cross the valve, they pass a wire into the aorta and then dilate the subvalvular region with a small 8 millimeter balloon. And then that will create a passage for the iono balloon to track, and they will do it. Another case which we have done 2-3 cases is a dextrocardia and balloon valvotomy. Here and then most of the cath lab machines, you can invert the image. You can just invert the image and do it. But only thing is all your movement should be the opposite direction. That you have to be careful. Even though the image is inverted, all your rotation, everything should be in the opposite direction. We punctured the left side, and the angulation also. The standard 3-4 should be 8 o'clock, 7 or 8 o'clock. That should be the mirror image of when you descend, the dial of the broken burrow will be at 7 to 8 o'clock position. So in these cases, we always take a pulmonary PA angio levo phase to see the septum, the orientation of the septum. It will be much easier so that you will not make any mistake. So here we are dilating, and here also we had to use a reverse loop entry in this case because it was difficult otherwise to enter into the valve. This we have reported. And BME in pregnancy is another area because we do it under around 5 to 6 months. Always we try to reduce radiation, avoid angios, hemodynamic studies, just straightly go into radiation shield for abdomen, iono balloon technique, underdilate the valve to tide over the pregnancy and avoid. And this is our series of long-term outcome of pregnancy BME. The last thing is the BME with the LA appendage clot. When the LA body clot is a absolute contraindication, but when there is a LA appendage clot, you can do an over-the-wire technique and do it. And in the Jayadeva series, out of 108 cases, they had only one TAA. So LA appendage restricted clot, you can give anticoagulation for 2-3 months and do the BME. And a cardiac tamponade, one word I should caution you is that early detection is the key. So after you do the septal dilatation, do an echo and see whether there is some effusion. If the effusion is there, just wait to see whether it is increasing or not. And if it was only a needle puncture, wait and watch, no heparin, only a needle puncture, usually nothing will happen. If you have dilated the septum, and if this, I will take only a few seconds. If it is torrentially leaking, what you can do is you can keep the dilator across the septum. That will arrest the bleeding to some extent. Then you can aspirate and see and or send the patient for surgery. If the effusion is small, better to perform the BME because it will reduce the LA pressure, the leak will be lesser. And this is the case which we have aspirated and we proceeded with the BME and the patient did well. So to conclude, BME may rise to difficulties occasionally, but most of the times we will be able to do some maneuvers and able to cross the valve by either a reverse loop or something or a modified one and do it. Thank you.
Thanks, Dr. Hari, for sharing.